Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith Rogers. Welcome back to this special series of Public Health in the Field dedicated to addressing the Black maternal health crisis in the United States. In this episode, co-hosts Dr. Rachel Burvell and Annalise Winnie will explore how government policy can help shape the solutions to this ongoing crisis and some ways in which it already has. Before we begin, we recommend that listeners check out the first episode in this series, which gives an overview of how and why the nation has come to recognize the severity of this crisis in recent years. And a quick note about the language used in this series. While we use the terms maternal and women throughout this podcast, we do acknowledge that not all individuals who give birth identify as women. Let's listen.
Welcome back to this special series of Public Health in the Field. I'm Rachel Burvell.
And I'm Annalise Winnie.
As Mother's Day approaches, we're reminded of the countless moms and maternal figures who shape our lives and communities. As they know, becoming a parent is a transformative experience.
And anticipating it can be incredibly exciting, full of amazing highs like the possibility of finding out the sex, that first ultrasound, hearing the heartbeat, choosing a name, and also some dreaded milestones like morning sickness. But sadly, the prospect of giving birth in America can also be a terrifying one, especially for Black women who face devastating maternal health outcomes.
Yeah, the stats bear repeating. Black women are 3 to 4 times more likely to die from pregnancy-related causes than white women, a shocking statistic that has been gaining more attention in recent years.
And to be more specific, in 2021, 1,205 women died of maternal causes in the United States, compared with 861 in 2020 and 754 in 2019. That means that between those 2 years alone, the maternal mortality rate went from 20.1 per 100,000 live births to a staggering 32.9 deaths.
To address these disparities and find real solutions, we need to first home in on the elements that lead to a healthy delivery. Let's think about it. What supports a healthy pregnancy? First and foremost, being healthy before pregnancy. That means that policy should provide access to preventive care, such as regular checkups and screenings, to identify and address any pre-existing health conditions that could complicate pregnancy.
And second, quality prenatal care. Regular visits with healthcare providers, access to appropriate diagnostic tests, and a personalized care plan that takes into account a woman's individual health needs and risks. And third, what happens outside of the clinic walls matters too. I'm talking about access to healthy food, safe and affordable housing, transportation, and adequate income to support oneself and their family. These key resources are known as the social determinants of health, or the non-medical drivers of health.
Fourth and finally, let's not forget about the need for continued support after delivery, because nearly half of maternal deaths are happening within the first year postpartum.
And unfortunately, the nation is not supporting Black mothers well at each of these steps. Because of systemic racism, discrimination, and other barriers, they experience poorer health before pregnancy, less access to prenatal care, and difficulty accessing resources during pregnancy, and more challenges after pregnancy.
All of this underscores the urgent need for policy improvements to address the Black maternal health crisis. Today, we'll talk about 5 specific policy solutions that are moving the needle towards better maternal health outcomes and where they stand.
First, we're going to start with one we're making good progress on: extending Medicaid coverage after birth. 42% of U.S. mothers are covered by Medicaid, the joint state and federal healthcare program for low-income Americans. That number is even higher for Black women at 65%. So the details of Medicaid policy coverage matter a whole lot to the health of American moms and their babies, and to the disproportionate share of Black women who rely on these services.
But who qualifies? What's covered and for how long varies by state, right?
Right. So at the baseline, all states must cover basic services, including prenatal care, childbirth and delivery, and provide these pregnancy-related services for 60 days postpartum. But as advocates have long pointed out, 60 days is just not enough time for new mothers to fully recover from the physical and emotional toll of childbirth. And after that 60-day period, in some states, many women fall into what's known as the Medicaid gap. They earn too much to stay on Medicaid once they're no longer pregnant or immediately postpartum, but they don't earn enough to afford private health insurance. And research shows that people who fall into this Medicaid coverage gap are disproportionately people of color.
Childbirth can be a really traumatic experience, whether emotionally or physically. So losing your health coverage that shortly after having such a major health experience happen to you can add to the trauma and add to that stress that Black women are feeling after giving birth.
That's Veena Smith Ramakrishnan. She's a senior policy associate working on issues related to maternal health and reproductive rights at the Century Foundation. That's a think tank that contributes to making the policy landscape more equitable for all populations in the U.S. Loss of health coverage is cited as one of the top reasons many women miss out on postpartum care, which means potentially missing the chance to flag health complications that occur beyond those first 12 weeks when they're covered, and therefore missing the chance to address concerning signs and symptoms of mental health issues and substance use, or to manage chronic illnesses like diabetes and high blood pressure, which are major drivers of the high U.S. maternal mortality rate. Here's the good news. Dozens of states have already extended pregnancy-related Medicaid to 1 year, in part thanks to policy that has made it more appealing for states to make those changes. An under-the-radar provision in the Biden administration's 2022 year-end omnibus bill made it easier to permanently extend postpartum Medicaid coverage to that full year, with federal funding footing much of the bill. That option was initially part of the 2021 American Rescue Plan Act, which was put in place to help the country recover from the COVID-19 pandemic. So what this means is that if states opt in, there's no risk of ever losing matching federal funds to pay for postpartum Medicaid. And that may have helped entice some holdout states to opt in. Mississippi, for example, finally adopted postpartum Medicaid expansion in March after blocking it for several years. Here's Smith Ramakrishnan again.
It can make a really huge difference in people's ability to not feel that stress. Okay, I have health coverage. I'm going to be okay if, not necessarily feeling afraid that going to the hospital is going to put you in debt for a life-threatening health emergency postpartum. That's a huge relief for a lot of people.
But here's the thing. Expanded coverage is not mandatory for states, and that means many women are still losing out on care during the crucial first year after childbirth. So what would it look like if all states extended Medicaid to a full year postpartum? It would mean that 720,000 people would gain additional months of coverage compared to what they have now.
A lot of the states that have yet to extend postpartum Medicaid coverage to 12 months are also states where they have the poorest maternal health outcomes in the country. So the people who need it the most are still not necessarily getting it.
At the time of this recording, 3 states are pending passage of this legislation.
Alaska, Missouri, and New Hampshire.
Another 3 have limited coverage, or less than 1 year.
That's Texas, Utah, and Wisconsin.
And 7 states have not yet acted to extend 12 months of postpartum coverage at all.
That's Arkansas, Idaho, Iowa, Montana, Nebraska, Nevada, and South Dakota.
So while we've made a lot of progress, there are pockets of the country where women are losing out on essential care, putting them in danger of the worst maternal health outcomes.
Having health coverage is, of course, essential, but it's just one piece of the puzzle. Women also need to be able to support themselves while they care for a newborn and shoulder all of those new expenses that come with it. And that's where paid parental leave comes in, or unfortunately in this country, lack thereof. This is the second policy solution we're going to be talking about today. The United States is one of only a handful of countries, along with Papua New Guinea, the Marshall Islands, Micronesia, Nauru, Palau, and Tonga, that does not have a national policy guaranteeing paid leave to new parents.
That's 0 weeks of paid parental leave. Compare that to another high-income country, like the UK, for example, where a working mother can take up to a full year of maternity leave, with 39 of those weeks being paid.
Right, whereas many American parents are forced to return to work too soon after giving birth, putting their health and the health of their babies at risk. And evidence shows that job-protective paid parental leave is essential for healthy moms, babies, and communities. For instance, access to paid parental leave around the period of childbirth can reduce rates of infant mortality, low birth weight, and preterm births. It can increase breastfeeding rates, alleviate perinatal mood disorders, including postpartum depression. It can lead to increased immunization uptake and decreased rehospitalizations.
So as a country, we're really lagging on this issue. And it's easy to see the direct link between the lack of paid parental leave and the dire maternal health outcomes we've been discussing throughout this series. While paid leave is yet to be federally implemented, many efforts have been underway to change this. For example, the Family and Medical Insurance Leave Act, or the FAMILY Act, which in 2021 was introduced to Congress by Senator Kirsten Gillibrand, Democrat from New York. Gillibrand has introduced this bill 5 times since 2013, and while it's yet to pass Congress, it's gained more support each time, with 6 co-sponsors in 2013, then 21 in 2015, and 37 when it was last introduced in 2021. It aims to provide workers up to 12 weeks of their partial income for health issues, or in response to the birth of a child, or placement of a child through adoption. Here's Senator Gillibrand speaking in March 2017 about it.
Imagine a woman who has just given birth, but she doesn't have any vacation days or sick days to be able to use. She has certainly no maternity leave or family leave. She has to make that tough choice. Do I stay home with my baby that absolutely needs me and quit my job, or do I go to work and actually bring home the paycheck that I desperately need to feed that child? That is a real life consequence and reality for too many American families.
The Build Back Better Act attempted to incorporate proposals from the Family Act, but it did not pass the Senate in winter of 2021. Earlier this year, in 2023, the White House celebrated 30 years of the Family and Medical Leave Act, or FMLA, which has allowed up to 12 weeks of unpaid leave. The anniversary reiterated the need for the nation as a whole to follow in the footsteps of the 11 U.S. states that have taken it upon themselves to pass paid family and medical leave laws. Now, let's turn to a third policy solution: telehealth.
Right. So, first of all, what exactly is telehealth?
Telehealth incorporates various remote health services, from video conferencing with doctors, checking health results online, to remotely monitoring health conditions. The COVID-19 pandemic forced the country to more fully embrace these virtual options for healthcare, and many of these were made official through various measures in the landmark COVID-19 relief bill, known as the CARES Act. During the first 2 years of the pandemic, use of the telehealth services increased 38-fold in the U.S. Through what began as a forced experiment, it became clear what advantages telehealth offered beyond just helping patients avoid COVID-19 during lockdown, and those included helping pregnant women access the care they needed more easily. These provisions are yet to be codified into federal law, but the 2022 Omnibus Spending Bill that we mentioned earlier extended COVID-era rules that made it easier for many Americans to access telehealth services to 2025, and telehealth providers are angling to make it permanent.
There is no substitute for being in person. That being said, there are some things that you can do either digitally or in person. And it wasn't until COVID-19 when people were like, well, maybe people who are pregnant are not the ones we want coming into a facility unless they really need to, where we went from a century-old fixed model to 1,000 natural experiments across the country, and thinking with precision about what should happen digitally and what shouldn't.
That's Dr. Neil Shah. He's Chief Medical Officer of Maven Clinic, which is a digital provider focused on family health care. So every day at work, Dr. Shah sees the benefits of telehealth up close.
What excites me most are the things that can only happen digitally. So the ability to connect with somebody at 2 a.m. within 30 minutes, the ability to make sure that, if you're Black and you want to talk to a Black provider, that you can do that with the economies of scale that digital can create, the ability to look through a phone at someone's refrigerator and coach them on their nutrition options.
Since the pandemic, many states have incorporated telehealth provisions into their health programming. After receiving federal funding earmarked for maternal health initiatives, the state of Maryland developed MD Mom, the Maternal Health Innovation Program. This 5-year program aims to lower the burden of preventable pregnancy-associated complications and deaths, while reducing racial ethnic, and nativity disparities. And that is done through 5 key strategic areas. One of those areas, expanding telehealth services. One of the ways Maryland is doing that is by targeting the hypertensive disorders of pregnancy. Referred to as the silent killer, hypertension or high blood pressure is a key driver of maternal mortality. And when higher pressures occur during pregnancy or postpartum, Black women tend to suffer the most, as they experience more adverse outcomes compared to their white counterparts. The MD Moms Telehealth Initiative coordinates with hospitals and patients to provide 2 options for eligible patients: free blood pressure cuffs and educational materials for self-monitoring, or referral to a 24/7 telehealth nursing surveillance system. This allows for healthcare teams to intervene much quicker if potential problems arise.
So this is just smoothing out some of the barriers and making it a really low bar to be able to provide these to any woman who potentially could benefit.
That's Dr. Carrie Wolfson, assistant scientist and co-investigator for MD Moms. But as Wolfson points out, this is a brand new program.
That initiative was just rolled out a few months ago, so it's still kind of gaining momentum. I believe the statistic now is about 6 blood pressure cuffs are going out to patients every day across the state through that initiative.
6 blood pressure cuffs going out per day is an impressive number. But Wolfson notes that in order to ensure that the project is truly saving lives, it is critical to consistently track data and evaluate how the initiative is playing out in practice. For example, are women who get those cuffs using them? And are care teams responding to concerning readings in a timely manner?
For any public health effort, data collection, whether it tracks the effectiveness of a policy or counts maternal deaths, is essential. So that's our next policy solution. Again, Dr. Shah, as he said in the first episode of this series,
you can't fix what you can't see, and you can't see what you're not measuring.
Updated information on the state of maternal health in the United States is often fragmented and not transparent. This slows down opportunities to react to alarming morbidity and mortality rates. Incomplete and inconsistent data collection also means that solutions are not deployed when they need to be, slowing attempts to address existing disparities.
For its part, though, New Jersey is working to change that. After receiving notice that the state ranked 47 out of 50 for maternal mortality overall in 2018, with Black women 5 to 7 times more likely to have complications compared to their white counterparts, the state decided later that year to codify into law the New Jersey Report Card of hospital maternity care. Updated annually and published on the state's Department of Health webpage, the report gathers and compiles birthing information by hospital so that patients can make informed decisions about their care and hospitals can be held to a higher standard. Reporting on rates of complications and deaths helps to accelerate change and boost quality improvement. The ultimate goal is to make births safer, especially for Black women.
The last policy effort we'll discuss is the largest, most ambitious congressional package to date, aiming to confront the Black maternal health crisis from the federal level, the Black Maternal Health Momnibus Act of 2021. The Momnibus builds on existing legislation and many of the efforts we've discussed so far to comprehensively address the nation's maternal mortality crisis. Introduced by the Black Maternal Health Caucus, which is co-led by Representative Lauren Underwood, Democrat from Illinois, and Representative Alma Adams, Democrat from North Carolina, the Momnibus makes investments through 12 standalone bills. There's a bill for investing in social determinants of health and another for funding community-based organizations.
There's also a bill to grow and diversify the perinatal workforce,
a bill dedicated to improving data collection,
and one for strengthening use of digital tools like telehealth,
and another that supports moms and babies exposed to climate change-related risks.
There's also bills dedicated to helping high-risk groups like those with mental health and substance use concerns, veterans, incarcerated people, and Native American populations.
Representative Underwood, who herself was inspired to action by the passing of her friend and colleague, Dr. Shalon Irving, shared her vision of the Momnibus with the House Committee on Oversight and Reform in 2021.
I urge my colleagues to support the policies in the Momnibus, which are even more important in response to a pandemic that has both underscored and intensified the need to make robust investments in high-quality care. At the heart of these investments is the principle that in America, every family has the right to thrive, a principle that begins with a safe and healthy pregnancy and birth.
Now, to date, only one element of the Momnibus has made it into law, and that concerns veterans. It's called the Protecting Moms Who Served Act, and it was signed by President Biden in 2021. The other bills, they were included in the ill-fated Build Back Better package, which passed the House with broad bipartisan support, but it failed in the Senate. If eventually passed in full, though, the Momnibus package has the potential to make a major impact on maternal health outcomes. And that's because of its emphasis on the full slate of socioeconomic factors that impact a pregnancy. Or what the founder of the National Birth Equity Collaboratives, Dr. Joya Crear-Perry, describes as the social determinants of maternal mortality.
In other words, to address clinical concerns, we must invest in policies that influence the social, racial, and gender disparities contributing to disparate healthcare access and outcomes. We need evidence-based policies that uphold the tenets of reproductive justice and ensure that environments in which people are pregnant, birth, and raise children are safe and healthy. This is especially important to providers and community members confronting aspects of the Black maternal health crisis face-to-face. Physicians like Dr. Jamila Parrott, President and CEO of Physicians for Reproductive Health. She has made advocacy efforts her focus.
I spend more time doing policy work than I do clinical care now. And it's not because I love the work more than I love taking care of people, but because the impact is so great when we think about the role that both federal and local policy can play in our health and well-being. Right. And so we have to get to those folks that are writing these laws and be clear and direct about what the impact is and why or why not, why we will or will not support this policy and legislation, and why they, as our employees, right, we cannot forget that these folks who are elected are employees of the citizens of this country, why we will not allow them to continue to pass these policies that we know are harming our communities. There is definitely a role for both federal and local policy in this, but that policy, those policy decisions, that legislation must be informed by the needs of those most impacted.
Dr. Parrott's words illustrate the critical role of policy in improving maternal health outcomes, keeping in mind that the best efforts are deeply guided by the work of advocates and communities on the ground who raise up the stories and the needs of their communities too.
So we need to listen to Black women, to see what their concerns are and build policy around them. And we need to invest in the people who are already on the ground doing that work.
So that's where we'll go next. Join us next time in the final episode of this series. We'll explore the revolution in maternal health that's happening outside the policy space, but that also informs it.
We'll explore how Black moms, community advocates, and a new generation of medical trainees are taking this issue into their own hands, and how everyone can contribute to solutions. Thanks for listening. We hope you'll join us next time.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.